Nichols from the University of Otago, New Zealand. The title is Impact of Socioeconomic Factors on Oral Health-Related Quality of Life in a Cohort of Orthodontic Patients.
Firstly, I'd like to start by thanking the scientific committee for accepting this work for an oral presentation. Good afternoon. Today, I would like to share with you some of the work that we've been doing at the University of Otago. Here is a brief outline of what I hope to cover today. I'd like to start by giving you a little bit of background into my topic, which revolves around orthodontic treatment and quality of life. Orthodontic research has traditionally used clinical indices as a means of measuring patient outcomes. However, recently, there's been a shift in the focus of this research to a more patient-centered approach through the use of oral health-related quality of life indices. Much of the literature has found that there is an association between malocclusions and quality of life, and obviously orthodontic treatment has an impact on this. If you take a look at some of the recent papers that have been published about this relationship, you will find that some of them have found an association, but others have found none. One possible reason for this is the confounding effects of personal, social, and environmental factors, which were not taken into account in these studies. So if we go back to this relationship between malocclusion, orthodontic treatment, and quality of life, it's important to consider some of the potential confounders, which include personality traits and psychological factors, which relate to the patient's self-esteem and state of mind. Socioeconomic status is also a potential confounder, and that has been the focus of our research. So how do you measure socioeconomic status? There are two ways of measuring it. The first is an individual-based measure, and this looks at occupation, education, and salary. The second is an area-based measure, and this uses deprivation indices. One example of an area-based measure is the NZ Dep 13, and this was especially developed for New Zealand. This index takes into account a range of different components, ranging from home ownership to employment. A deprivation score is derived for each geographic mesh block, and each mesh block contains around 80 individuals. If you take a look at the city of Christchurch as an example, you can see how our city has been broken down into many different colours, which represent the different mesh blocks. These mesh blocks also correspond to a different deprivation index, which ranges from high to medium to low. And if you look at the impact of deprivation on oral health-related quality of life, you'll find that there is an association in some studies, but not in others. And this could be due to the variable degree of severity of malocclusions. It is plausible that the impact of socioeconomic status diminishes with increasing malocclusion severity. So this led us to our research question. Does socioeconomic status influence oral health-related quality of life in patients with severe malocclusions? Our goal was to investigate the association between area-based socioeconomic status and oral health-related quality of life in patients with severe malocclusions. So let's now take a look at the methods that we used. Our study was a prospective observational study. It followed 75 consecutive patients, all recruited from a hospital setting. All of these patients had severe malocclusions of a wide spectrum, and they were all treated by a single orthodontist. There was strict eligibility criteria for entry into the study, and this included having a severe malocclusion and a willingness to participate. Patients with genetic syndromes were not included in the study. If you take a look at a timeline of the study, you can see that before the patients began treatment, we recorded their demographics, socioeconomic status, DI score, and the OHIP 14. Then the patients underwent treatment, and then once the treatment was complete, we recorded the OHIP 14 again. We use the DIE score as a measure of malocclusion severity, and as many of you know, the DIE score is a composite score derived from 10 different occlusal traits, ranging from crossbites to diastemas. The DIE score has been found to be both reliable and valid. Once a patient's score has been derived, they can be further classified as having a normal to minor malocclusion for scores less than 25, a definite malocclusion for scores between 26 and 30, a severe malocclusion for scores between 31 and 35, and a handicapping malocclusion for scores greater than 36. All of the patients in our study had a score greater than 36 and therefore had a handicapping malocclusion. The second thing that we chose to study was the oral health-related quality of life. This is a multi-dimensional concept and involves measuring patients' perceptions about their oral health. One example of an index that does this is the OHIP 14, and this takes into account a number of different components, ranging from psychological disability to social disability to physical disability. All of these components can come together to form a final score, or they can be looked at in isolation to better understand the impact that the patient is experiencing. So just to recap, the OHIP 14 ranges from 0 to 56, and the greater the patient's score, the poorer their quality of life. So let's now take a look at our results. There was an almost equal distribution of patient types and an almost equal male to female ratio. Overall, there was a reduction in the OHIP 14 when comparing baseline and post-treatment. However, most importantly, there was no significant difference between the three deprivation groups, both at baseline and again at post-treatment. Here we've broken the OHIP 14 down even further, and you can see how along the x-axis all of the subdomains run. If you take a look at the green column, you can see that it corresponds with low deprivation. The orange column represents medium deprivation, and the red column represents high deprivation. Two conclusions can be drawn from this graph. Firstly, the psychological domain had the greatest impact for patients, and this is consistent with the findings of other studies. Secondly, and most importantly, even when you break the OHIP 14 down into its subdomains, you can see that there is no significant difference between the three deprivation groups within each subdomain. And if you take a look post-treatment, you can see that overall there was a reduction in the OHIP 14. However, once again, there was no significant difference between the three deprivation groups within each subdomain. We used a multivariate model to analyse our data, and what we found was that the severity of a malocclusion was the only thing associated with treatment-related changes in the OHIP 14 after adjusting for age, gender, and socioeconomic status. So when we go back to this relationship between malocclusion, orthodontic treatment, and quality of life, it's safe to conclude that socioeconomic status does not play a major role for patients with severe malocclusions. Let's now take a look at some of the study's limitations. Our study was limited by its small and varied sample size. The external validity was limited by the fact that the patients were recruited from a hospital setting, so they all had severe malocclusions. We also had a lack of untreated controls. Despite these limitations, I feel that it's safe to conclude that patients with severe malocclusions report significant improvements in their oral health-related quality of life following treatment. These improvements are not influenced by socioeconomic differences. However, it would be useful to use individual-based measures as a means of measuring this as well to complement the findings of this study. If you'd like any further information about this study, you can have a look here. Thank you for taking the time to listen.
Thank you, Dr. Nichols, for this nice presentation. And I want to tell that the next speaker, that is Faizan Alim, is not going to present his presentation.